welcome to join us at this PCR e-course. We are going to talk about looking at DES and STEMI in the context of the BioSTEMI trial. This session is sponsored by Biotronic. I am Stefan James, an interventional cardiologist from Uppsala, Sweden, and I'm happy to be joined today by two friends and colleagues from the EAPCI family. I have Juan Iglesias from Geneva, Switzerland. Hello, welcome, Juan.
Hello, Stefan.
He's an enormous experience in primary PCI and stents in general, and Orsiro in particular. I'm also joined by Gioel Secco from Alexandria, Italy. Hello,
Hi,
Gioel. Welcome. Also
Hi.
with a lot of experience in drug-eluting stents and imaging in patients with STEMI. So just to get started here, I'd like to ask Juan about what is the importance of STEMI treatment in today's world of PCI? Can you just give an introduction?
Yeah, well, as you know, STEMI is the most acute clinical presentation of coronary artery disease, and despite its incidence has declined over the past 20 years, it remains associated with unacceptably high morbidity and mortality rates. When we compare patients with chronic coronary syndrome, STEMI is mainly caused by the acute rupture of a vulnerable atherosclerotic plaque and the subsequent thrombus formation. And this results in complete coronary artery occlusion that leads ultimately to myocardial infarction and permanent myocardial damage. And therefore, the acute treatment of STEMI is mainly focused in provide rapid and effective myocardial reperfusion of the occluded artery. And nowadays, primary PCI is the recommended reperfusion strategy over thrombolysis for acute STEMI, provided this treatment can be delivered in a timely fashion within 2 hours of STEMI diagnosis. We have now several studies that have shown a progressive and consistent reduction in acute and long-term mortality rates, but however, we have to face the fact that in-hospital mortalities in unselected STEMI patients is now plateauing around 5 to 10% in the European national registries, and 20% of these patients will still experience a recurrent cardiovascular events within the year following the STEMI. So therefore, I think that the management of STEMI is nowadays still a major public health concern, and this discloses the need for a continuously iterative developments and refinements in drug-eluting stent technology to further improve these patient outcomes.
Yeah, thanks, Juan. I couldn't agree more. So this is very important, and there are specific issues with primary PCI. So, Gioel, what do you think are the most important challenges we are facing in the cath labs when treating STEMI patients in relation to these timing issues and the specific healing mechanisms that we're seeing?
Well, Stefan, the first thing is that when we are facing a STEMI patient, the first thing is that we really don't know this patient because we don't have any data about the clinical history of the patient. We are in a hurry. We don't know if the patient will be able to stand a long dual antiplatelet therapy. And also we don't have that much time to see the real vessel diameter that we have to treat. And we don't have time to probably use additional imaging because we have to open the vessel as soon as possible. So in this setting, having new devices that will allow us to using, if needed, short adapt, or even if will somehow protect a little bit more the patient and forgive a little bit more the operator if he's somehow misunderstood the real vessel diameter, will certainly improve our results. And I think that in so forth, probably the new devices that are coming out, the thinner struts, can somehow really help us in provide better PCI to our unstable patients.
So there are so many issues that we are facing. How is really the choice of DS, the type of stent, important in this setting?
I mean, absolutely. I think that we have now evidence over the last decades that newer generation drug-eluting stents with either biocompatible permanent polymers like the Zyme stents in the examination trial, or with biodegradable polymer coatings. This was the biometrics stents in the comfortable MI trial, that both of them have substantially improved both safety and efficacy outcomes compared with bare metal stents in patients with acute STEMI. And accordingly, when we look at the most recent 2017 ESC guidelines for the management of acute STEMI, the use of newer generation drug-eluting stent over BMS is now currently supported with a Class 1A recommendation. However, we have to acknowledge that to date, no head-to-head randomized clinical trial has evaluated whether there would be an incremental benefit of different newer generation drug-eluting stents with different designs among patients with acute STEMI.
So that leads us into our main focus for the discussion, Juan. There have been incredible advances and more trials have been performed. And can you just lead us into the discussion about the evidence for different platforms and the trials that you have been involved in?
Yeah, sure. So if we summarize, I want just here to summarize the evidence supporting the use of the Osiro stents in patients with STEMI. And this comes back to the Biosense trial, which was an investigator-initiated randomized non-inferiority trial that was performed among more than 2,000 all-comer patients with chronic and acute coronary syndromes in Switzerland back in the early 2010. And this trial compared the Osiro biodegradable polymer sirolimus eluting stent with the Zions durable polymer everolimus eluting stent. In the overall trial, at 1 year, the primary endpoint of TLF was similar among both treatment groups. But when we look at the stratified analysis of the primary endpoint, we found out that in the pre-specified subgroup analysis of patients with STEMI, there was a lower TLF risk among patients treated with Osiro when compared to Zions, and this was a rate ratio of 0.38 with a highly significant p-value for interaction. So therefore, based on this signal and these exploratory findings, based on only 407 patients, we designed this BIOSTEMI trial as an investigator-initiated randomized trial with the objective to compare two contemporary new generation drug-eluting stent, the Osiro biodegradable polymer sirolimus eluting stent and the Zions durable polymer everolimus eluting stent among STEMI patients treated in a contemporary clinical practice. Interestingly, we used Bayesian statistical methods, and this was one of the first time this kind of statistical approach was used in coronary stent trials. And the principle here was to use robust priors as to incorporate the historical information from these 407 patients that were included in the Biosense trial. And actually, this was in the way to downgrade the risk of type 1 error if the new prospectively acquired data would turn out to be different from the historical information. We use the primary endpoint of TLF as a composite of cardiac death, target vessel myocardial reinfarction, and clinically indicated TLR at 1 year. But it's really important here to highlight that BIOSTEMI was the first randomized controlled trial that was powered for superiority to compare two new generation drug-eluting stents in an exclusive patient, STEMI patient population.
So very important study. Can you guide us through this slide showing the change over time and the divergence of the event curves?
Yeah, sure. So in the BIOSTEMI trial, we found out at 1 year follow-up that the Osiro biodegradable polymer sirolimus eluting stent was superior to the Zions durable polymer everolimus eluting stent with respect to TLF at 1 year among these STEMI patients. And when we look at the cumulative incidence of the primary endpoint, according to these Kaplan-Meier estimates, it was 3.9% in patients treated with Osiro versus 5.5% in patients treated with Zions. And therefore, the superiority of Osiro was declared with a rate ratio of 0.59 and the Bayesian posterior probability for superiority of 98.6%, which was above the pre-specified threshold of 97.5. Interestingly, the difference was driven by a lower risk of clinically indicated target lesion revascularization, 1.4% with Osiro, 2.6% with Zions, corresponding to a rate ratio of 0.55 and a Bayesian posterior probability of superiority of nearly 95%. And interestingly, as you can see in the slides showing here the secondary endpoints, we found little evidence for differences in the occurrence of cardiac death and target vessel myocardial reinfarction, but also in rates of definite stent thrombosis at 1 year between the two treatment arms.
So very important and impressive results. What do you think are the most important factors contributing to this difference over time?
Well, I mean, we have to assume that the exact mechanism explaining this significant reduction in TLF within the first year after DS implantation in patients treated with Osyro remains incompletely understood and warrants probably future study, probably including intracoronary imaging. Interestingly, what we see from these Kaplan-Meier estimates is that the clinical benefit of the Osyro seems to emerge already within the first 12 months after DS implantation. And this is well before the degradation of the polyl-lactic acid polymer and exposure of the blood flow to the passive silicon carbide coating of the Osyro that has been previously shown to reduce thrombogenicity and facilitate healing. However, I mean, in addition to the polymer coating characteristic itself, the metallic stent platform composition, geometry, strut thickness are also additional features in a DS design that potentially can impact on the early outcomes. And this has already been shown previously that the reduction in strut thickness mitigates inflammation, vessel injury, thrombus formation. And we have now data now from these very large meta-analysis of a randomized control trials showing that ultra-thin strut DS are associated with lower TLF rates when compared to thicker newer generation drug-eluting stents. However, we have also to assume here that in a stratified analysis of the primary endpoint, we did not find differences in clinical outcomes between patients treated with small vessels versus large vessels. And this can be used as a surrogate comparing ultra-thin versus thin struts, but this was only a subgroup analysis and deserves probably future larger studies trying to answer, or at least to make sure that this ultra-thin hypothesis is confirmed. And finally, the longer-term follow-up of the trial will be important to see whether these diverging curves still continue beyond 1 year, and we will be presenting the 2-year data later this year in a major congress. And tomorrow, we will be presenting as an outline session, late-breaking trial session, a subgroup analysis of the BIOSTEMI trial, looking at differences in outcomes among patients treated in small versus large vessels as a surrogate to compare ultra-thin versus thin strut. And this will give additional insights into this ultra-thin theory supporting the data of the BIOSTEMI trial.
So Gioel, you need to comment on the findings that you have done, showing and proposing what is the evidence suggesting that the ultra-thin struts results in better outcomes. Can you guide us quickly through that, your experiences?
Well, Stefan, it's kind of easy to understand actually that there is some difference between, as Juan was telling us, thicker and thinner struts, because first, the very introduction of drug-eluting stents, we know that this technology was able to reduce the restenosis, but was associated with something in a small increase in late stent thrombosis that was considered as an avoidable drawback of the potency of the cytostatic potency of the drugs. Of course, these things has been now completely surpassed by the new technology, and the thinner struts compared with thicker struts are certainly able to provide less flow disturbances, and of course there is less material to be covered by the neointimal coverage. And in this small study, in the small pilot study that I performed a couple of years ago using OCT, I was able to demonstrate that the Osyro stent presented already almost 99% of struts that were covered already at 90 days. And if you think that the LEADERS trial showed that these results were achieved by the Cypher only after 2 to 3 years, and that the first 9 months, Cyrus only had the Cypher 9% of coverage struts. So this probably can help to understand why this device can really improve the outcome of our patients.
Thank you very much. So deliverability is also an important feature, and there's now an additional version of Osyro. The Osyro Mission has been CE marked and is available in your country, right? So what do you think are the virtues of this new delivery platform?
Yeah, so you can see here, summarizing this slide, the main features of the newest generation of the Osyro DES. Mainly compared with the first generation, the Mission introduces several changes. The shaft has been made more flexible to increase trackability. There's additional embedding process to further increase crossability. And finally, the hub was redesigned. So the platform stays the same. So you have all the features of the previous generation or Cyro. But I mean, what this stent actually provides is clearly to improve trackability and deliverability, to make this available and actually in life-saving situation and complex anatomy. So this was, as far as I know, the stent is available in Switzerland and most countries in Europe. And the product is being planned to be launched in other regions for this year. I had the privilege to use it, and it's really impressive how this new platform improves the trackability and deliverability of the stents, even in complex scenarios, and as I mentioned, in life-threatening indications like STEMI patients and acute coronary syndrome patients.
Thank you very much. With that, I would like to thank you both for contributing to this very important session. I have learned that primary PCI still is a very important therapy for patients with ST elevation and myocardial infarction. The stent selection remains very important. Stents with the good deliverability, with thin struts, have an ability to reduce the risk of repeated events. And we can, by selecting the right type of stents in the right setting, in the right medical therapy, we can provide our patients with a lower risk and superior outcome in the short and the long term. So thank you very much for your contribution to this session. And I hope you learned something, you who listened to this. I certainly learned a lot. Thank you very much.